Today's topic is Headache Illustrated Presentation. I am Dr. Zakir Hussain, Senior ENT Consultant. There's a famous proverb which says, "The eyes will not see what the brain does not know." So today, I will knowledge you about in depth about headache. So, headache is a complaint of the patient. It's a symptom, not a disease. We have to find out we have to come to a diagnosis with this single complaint. How to go about? The classification of headache, we have three different types of classification. It can be classified as primary headache and secondary headache. The primary headache where there is no particular reason for it, which constitutes about 90%. And the rest 10% is the secondary headache, which I am going to talk about. Our great grandmaster from Austria, Dr. Stamberger, he has classified headache as sinus headache, non-sinus headache, and headache due to complex causes. So, we will start with history taking. History is most important to come to a diagnosis. I am going to deal with all these different types of headache. To start with rhinosinusitis. The history taking, first we have to ask the patient the onset, whether he has been suffering right from childhood or it started by adolescent or during adulthood. Then coming to the location, whether it is unilateral or bilateral, and the site, whether it's temporal region, around the eyes or in the occipital region, and the duration, whether it lasts for seconds, minutes, hours, few hours, the whole day or days together, and what is the frequency. Is it continuous or does it come in clusters, and the severity of the headache and the quality of headache, whether it's throbbing headache, piercing headache or stabbing type of headache. And we'll go ahead with aggravating factors, associated factors, and medical history, and whether he is on any chronic medication. Is there any history of head trauma or not? Is there any history of epilepsy or malignancy? And we'll go into examination. Examination, we'll start with vital examination, BP, pulse rate, temperature, and respiratory rate. And we'll do a complete ENT examination which includes even the TM joint. Now coming to the neurological examination, that also has to be done. That's about history taking. There are few red flags where we should be very aware. Soon after the history is over, just spare a minute for yourself. Just think, what are you dealing with? Are you dealing with a simple patient or are you dealing with a patient who needs immediate attention? We say red flag of headache. We have to ask a few questions more. Whether the headache, is it of sudden, severe, worst ever headache in the patient's life? Second, whether the headache is associated with neurological symptoms like any vision change or weakness, general weakness, or any state of confusion. Whether the headache is worsening over a period of 1 or 2 days. Is there associated fever or not? Is there a history of head injury? Is there associated nausea and vomiting which is increasing? Is there a history of malignancy or any state of immunocompromise in the recent past? So all this, if the answer is, if any one of this, the answer is yes, the patient needs immediate attention and we have to go ahead with imaging also. So the general investigation as far as the headache is concerned, and the ENT department, we shall do nasal endoscopy and do a CT sinuses. As far as the MRI and MRI scan brain and MRV and MRA, it goes to the Department of Neurology. That's what I told right in the beginning. The eyes will not see what the brain does not know. So if any one of us we know if the doctor knows how to read a MRI of the brain, say suppose diffusion weighted images, FLAIR images, CSS images, T1, T2 images, then you can go ahead and order for one. Otherwise, please leave that to the neurology department. So we will do a nasal endoscopy and we'll do imaging, CT scan, paranasal sinuses. Now, rhinosinusitis. Rhinosinusitis can be classified as acute or chronic. Usually acute, the history is straightforward. The patient complains of headache, nose blocked to start with, nasal discharge associated with facial pain and headache. Chronic, usually we come to a diagnosis, we have classified as major criteria and minor criteria. The headache comes under the, mind you, the minor headache comes under the minor criteria, not major criteria. The facial pain comes under the major criteria. So major criteria is more important. For frontal sinusitis, usually the location of the headache is in the frontal area, and it is otherwise called as an office headache, where the patient gets up from sleep with a headache and the headache increases over a period of time, and after say about 1 or 2 o'clock it starts subsiding. In case of maxillary sinus, it is located over the cheek area and is referred pain to the temporal area and the frontal. And as far as the ethmoidal sinuses are concerned, there will be pain around the eyes. It is otherwise called as the spectacle facial pain, headache. And last one is the sphenoid, where the pain is referred to the temporal region and sometimes in the occipital region. See, out of these 4, I'm mainly concerned about the sphenoid region. I had a patient when she is in her 40s and she presented with headache. I did a complete examination inclusive of nasal endoscopy, and the nasal endoscopy was normal. So I gave some anti-inflammatory, I sent her off. Next day she gave me a call and she said the headache has increased. Now I have eyelid swelling and I think I have got redness of the eyes also. I said, please come over to the clinic, let me have a look. She came over, I examined again. This is during photographs taken during the admission time. And as she said, there was swelling over the right eyelid. And I tried to open the eyelid. I saw that it is a whole congestion of the sclera. And she said the headache has become worse. It is increased. And the eye pain also has increased. So I did a blood test for her. The CRP was high. We got her admitted. And she being diabetic, we started controlling her sugar, asked for an urgent CT scan. In the CT scan, it came out as coryphungal sphenoiditis. So we gave, and the very next day, she started getting the pain around the eye increased, and the vision became blurred, and her eye movements also was restricted. So if you can see in the third picture, the right eye, the vision is straight. On the left eye, there is abduction. So there is failure of movement in the right eye. So MRI and MRV was advised by the neurologist, and the final diagnosis was right cavernous sinus thrombosis. She was operated upon the same day and she recovered only after a period of 6 weeks. Her vision came back to normal. Now coming to the next topic, migraine. Migraine is a chronic familial neurological disorder characterized by recurrent severe headache associated with autonomic symptoms. It can be classified as migraine with aura, migraine without aura, and migraine with aura is again subclassified. It comes in 4 different stages. To start with, it is prodromal stage. It goes to the stage of aura, then stage of headache, then you have post-headache stage. The patient complains of unilateral headache in 60% of the cases, usually it's unilateral, and bilateral in 40% of cases. and the type of headache will be throbbing or pulsating type of headache. Associated with that, there will be photophobia, osmophobia, sonophobia, and flashing of lights, and distortion of objects sometimes, which we often term as Alice in Wonderland syndrome. These are the features of complaints of the patient. Migraine, it's more common in females, and particularly after the age group of 20, and it has got a specific periodicity also. There are so many triggering factors for migraine. So, due to this triggering, though it is hereditary, due to this triggering factor, that there is activation of the trigeminal nerve endings. This leads to release of calcitonin gene-related peptide and substance P. These are powerful vasodilators which results in perivascular edema. This perivascular edema results in stretching of the nerves, of the trigeminal nerves, resulting in severe pain. That is the pathology behind it. This is what I have depicted in this picture. Now coming to the triggering factors. Few of the triggering factors are exposure to bright sunlight. Prone patients, even exposure of 5 or 10 minutes of bright sunlight is enough to aggravate an headache. Sleep deprivation, stress and strain, excess use of phone, chocolates, coming to diet, dried foods, fried foods, cheese, noodles, loud sound, bright light, henna application for a long time, periods in females, perfumes, and strenuous travels. These are the common triggering factor for headache in a case of migraine, in a prone patient of migraine. So coming to the investigation, this disease is a disease of exclusion. We don't need a specific investigation to diagnose. This is a disease of exclusion. So we'll do a nasal endoscopy to rule out sinusitis. We will ask them to get the refractive errors done to rule out refractive errors. You have an ophthalmology consultation to rule out refractive error. And CT scan, if there is a CT scan paranasal sinuses, if there is any positive finding in the nasal endoscopy. Coming to the treatment, we have treatment of acute episode and the preventive management. So the acute episode, we can classify the patient category into two types. One category is patient who work at home, and the second category is patient who work from home. Patient working at home, what I mean is the homemakers, housewives. The second category, working from home, are employees who work from home or even the office goers. So let us deal first with the first category, that is patient who is working at home. For them, the best thing is, since they have time, they can isolate themselves into a room, blindfold themselves, plug in cotton into the ears, apply ice over the headache region, and have a good sleep. If they want, they can take light anti-inflammatory like paracetamol or an antiemetic also. So this will be more than enough in most of the cases. Suppose they come under the second group, like work from home or they are in the office, they have to take any one of these drugs, which you call as TEN, that is triptans, ergotamine, and any of the NSAIDs. Coming to the triptans, I have written the whole list of triptans, which can be classified as short acting and long acting. And here I have written as available form, dosage, side effects, and contraindications. The most commonly used triptan is sumatriptan with a short acting, and the action starts say within half an hour. and this can be repeated after some time. The main contraindication for that is hypertension and angina pectoris. The mechanism of action of sumatriptan is it blocks 5-hydroxytryptamine 1B and D receptors, thus preventing the release of calcitonin gene-related peptide. If you in this list after sumatriptan, I want to just add up a point here. The rizatriptan can be used even in children above the age of 6 years. Next, coming to ergotamine, which is a little less costly when you compare with triptans. Ergotamine being the most common one. Here also, I have detailed about the different available as the dosage form, then what is the dosage needed and what are the contraindications. The mechanism of action of triptans are, it blocks 5-hydroxy-T1B and D receptors. And latest in ergot, we have Brekia, which is self-administrated, ready-to-use auto-injector, which is FDA approved. Coming to NSAIDs, there is a long list of NSAIDs in which the most commonly used one is naproxen. It acts by inhibiting the cyclooxygenase enzyme. Usually, along with all these medicines, we need to give an antiemetic also. The latest one is Emised. Coming to prevention. Who are the patients who need preventive medications? The first and the most important question is we have to ask them is this headache interfering with your day-to-day activities or not? 1. How many episodes of headache do you get? If the answer is 1 per week or more than 2 per month, they come under this criteria. Poor patient compliance, or the patient does not want to take medications. The last one being, we have complicated migraines like hemiplegia migraine, abdominal migraine, retinal migraine. They all need preventive therapy. So what are the preventive therapies? It can be grouped into 6 different types, starting with anticonvulsants. The most famous being topiramate. Topiramate, here also all the anticonvulsant medicines, I have put it as dose available, what is the dose needed, and what are the side effects. The topiramate, the mechanism of action is it is a sodium channel and calcium channel blocker, both sodium channel and calcium channel blocker, and it enhances GABA receptor too. The dosage required is 25 mg to start with. Usually we give in the night time. The main side effect is it hampers with the cognitive function of the brain, and there is weight loss. So with the patient who is already thin, we will not prefer medicines like topiramate. And another side effect is there's a chances of getting kidney stones. Coming to the next one, which is antidepressant, the commonly used medicine is amitriptyline, starting the dose of 10 milligrams. The third one being beta blockers. In beta blockers, propranolol is well known. The mechanism of propranolol is it decreases nervous system excitability, it stabilizes, it has got vascular stabilization property, it suppresses the aura, then serotonin regulation, and the last being stress reduction. This is contraindicated in bronchial asthma. So, some of the cases we prefer beta-1 selective beta blockers, which is Concur. The fourth being calcium channel blocker, and that the most famous being Cybelium or flunarizine. The mechanism of action of flunarizine is a calcium and dopamine channel blocker along with 5-HT1 receptor block. This can be easily given in a patient with bronchial asthma. Like how I mentioned before, we need an antiemetic also, like Emisset or Stemetil, to be given along with these medicines, but not regularly. In the miscellaneous group, we have riboflavin, with, which we give as 200 milligrams per day. This is mainly for the pregnant ladies, where they cannot take any other medications. Even magnesium can be added up with triptans, not triptans, it can be added up with topromide or ergotamine, topromide or calcium beta blockers. Magnesium 200 milligrams per day or at least 200 milligrams 3 times a week. The last one is coenzyme Q10. What is bridge therapy? Sometimes what happens is we give a full course of anti-migraine treatment. In spite of taking all the medicines regularly, the patient who has been taking medicine, who has been suffering from the disease for a long time, and we are taking medicines regularly, it doesn't get controlled because of that. So what we do is we stop all the medications, we start on steroids and mild anti-inflammatory medication. So the steroids will be given for at least 10 days. Then we'll stop the steroid and start with all the other anti-migraine medication. It is just like how we manage insulin resistance. So that is what we call as bridge therapy. Now coming to, so one more point to be added up is, whenever we give medicine, anti-migraine medication, it has to be given at least for a period of 3 to 6 months, because it takes time for its full effect to be on. It takes time, at least it takes about 2 months. So do not stop the medicine within 1 month. Especially please note, the propranolol should not be stopped immediately. If you stop any of the medications immediately, suddenly, it will lead to rebound headache. So alternative medicines. Definitely there is a role of injecting botulinum. Usually this is injected in 31 different sites. And the session has to be repeated also, which gives a relief-free period at least for 6 months to 9 months. The other alternative therapy are acupuncture, meditation, yoga, head massage, riboflavin minerals and vitamins, vitamin D, and minerals like vitamin D and riboflavin, minerals like magnesium, which I have already mentioned, regular exercise, and last being transcranial magnetic stimulation. The latest one is Nerivia, which is smartphone controlled armband. So whenever there is during the onset of headache, the patient can open the app, just switch on in the smartphone itself, the armband is activated and it can prevent a migraine attack. Recently, even melatonin was added in the treatment. How it acts up, it mainly inhibits the release of calcitonin gene related peptide, and it enhances GABA also. Not only that, it restricts dopamine and serotonin. It's the last one which I've written. It stabilizes normal sleep. It does not induce sleep. It stabilizes normal sleep. The recent advancement is to the next, for the future generation. What is going to come is, it's already been introduced. One plant has already been introduced. Is calcitonin gene related peptide antagonist. So I have named a few, in which we have oral tablets as well as nasal spray and injections. A step ahead in future, they are aiming to develop pituitary adenylate cyclase activating polypeptide inhibitors too. The research is still on. Prevention is better than cure. So I've given you whole list of triggering factors. So try to avoid sunlight, wear a sunglass, and or you can have a photochromatic spectacle and wear a cap also. Try to avoid stress and try to avoid overuse of phone. Here we have a rule of 20. For every 20 minutes of watching the phone, take a break of 1 minute. Every 20 minutes, get up from the seat, look at an object 20 meters above for 20 seconds. That is the rule of 20. Then avoid hunger and dehydration. Avoid chocolates, cheese, fried foods, soya related products, pickles, alcohol, bright light, loud sound, and perfumes. These are the triggering factors. You have to avoid all this. And of course, strenuous travel. Now, migraine, along with migraine, you can have coexisting disease. That doesn't mean that in migraine patient you should be having all this. Like neurologically, you can have anxiety, depression, and sleep-related disorders. In cardiovascular system, you can have atrial fibrillation and high possibility of heart failure, myocardial infarction, and gastroenteritis, colic, abdominal colic is very common. Ocular, its dry eye is very common. Endocrine, obesity and hypothyroidism, and as far as musculoskeletal system is concerned, fibromyalgia. Now, sequelae and complications. Sequelae means what follows a disease. They can have a depression, they can have sleeplessness, dizziness, rebound headache, stomach upset, difficulty in breathing, and numbness. Complication means the unwanted, unfavorable medical problem which follows the disease, which needs medical attention. Like for migraine, it is rebound headache, the possibility of ischemic stroke, arrhythmias like atrial fibrillation, chronic depression, vestibular migraine, even epilepsy, which is also often termed as migrapsy. So to summarize, the patient, a female patient, usually a female patient, unilateral headache with photophobia, sonophobia, and osmophobia, with so many triggering factors, and the headache duration of more than 4 hours and usually less than 32 hours. It responds well to triptans. This is about migraine. Now coming to cluster headache, it comes in clusters. The duration is less than 3 hours. For migraine, it was more than 4 hours. For this, it is less than 3 hours. And the patient says, the headache which is unilateral, as if a red hot iron rod has been pierced into my head. And there is a circadian rhythm for it. Usually, if he goes to sleep by 9 o'clock, say about 11 o'clock, he gets the episode. And it lasts for less than 3 hours. And it is very severe and can be aggravated with alcohol, if suppose the patient has taken alcohol then. The cause for that, why it has got a circadian, they say it can be because of irregular hormone production or genetic clock gene misfiring or REM sleep disturbance. What happens is this can lead to hypothalamus dysfunction, triggering the trigeminal parasympathetic system. It has got a periodicity and mechanism I have already mentioned. This like migraine, there's a diagnosis of exclusion, and imaging is just to rule out other conditions. Treatment, acute episode, we can treat with 100% oxygen from 7 to 15 liters for 20 minutes. Even ergotamine and triptan, they are really very effective for cluster headache. For prevention, verapamil comes in the first line. So, to summarize, we have two conditions now. One is migraine, where there is unilateral headache, which is throbbing type, pulsating type, and associated with you have 3 different types of phobia. It responds well to triptans. Now we have cluster headache, where there is a piercing type of headache, which is precipitated with alcohol, and there is a circadian, which is not there in migraine. And associated with that, the patient complains of facial swelling of the same side, eye congestion, lacrimation, and unilateral nasal discharge. And duration is less than 3 hours, responding well to oxygen. Coming to the third type, paroxysmal. The word paroxysmal means sudden onset that happens repeatedly. We have seen migraine, we have seen cluster headache. In paroxysmal, the episode, the duration is less than 30 minutes, but the frequency is more when you combine with migraine and cluster headache. It comes at least 20 attacks per day. It comes in clusters also. The neck movement is the triggering factor, usual triggering factor. Now the complaint is almost same like cluster headache. But cluster headache, it has got a circadian rhythm. This does not have a circadian rhythm. Again, like migraine and paroxysm in cluster headache, this is the diagnosis of exclusion, and imaging is just to rule out other diseases. Treatment, it responds very well to indomethacin. Indomethacin is considered to be a powerful cerebral vasoconstrictor. It alters the blood flow also, and it stops neurogenic inflammation. This does not respond to triptans or oxygen. To summarize, we have migraine, cluster headache, paroxysmal headache. We have so many triggering factors, three different types of phobia during the attack, and it responds well to triptans. Paroxysmal, aggravated with alcohol, specific circadian is there. There's a piercing type of headache associated with the facial swelling and redness of the eye and unilateral nasal discharge. Responds well to oxygen and triptans. Then we have paroxysmal headache, where neck rotation is aggravating factor, sudden neck rotation is aggravating factor, and the stabbing type of headache, and the time duration is less than 30 minutes. Here is more than 4 hours, next one is less than 3 hours, and paroxysmal is less than 30 minutes, and it does not respond to oxygen or triptans. Next we will go to two different types of headache, that is, one is SUNA, one is Sun City. That is, the full form of that is short lasting unilateral neurology form with cranial autonomic symptom. Here the unilateral headache, which is a burning type, lasts for less than 10 minutes, but the frequency about 600 times per day. The second one, that is short acting unilateral neurology form with conjunctival congestion and tearing, lacrimation also. Here the unilateral burning type of headache is less than 4 minutes. The frequency is about 200 times per day. So we have seen 5 different types of headache till now: migraine, cluster headache, paroxysmal headache, and SUNCT. Here you have throbbing type of headache with all the different types of phobia, and it responds, duration is more than 4 hours, less than 72 hours. Cluster headache aggravated with alcohol, piercing type of headache, this is definite circadian, and it responds well to oxygen therapy. Paroxysmal headache aggravated with neck rotation and stabbing type of headache. Here the duration is less than 30 minutes and it does not respond to oxygen triptan, but it responds very well to indomethacin. The last one, second last one, SUNA, where the triggering factor is cutaneous. Can be a touch will be enough, or maybe a blow of cold wind. And here the frequency is less than, the duration is less than 10 minutes. And the last one, Sun City, where the duration is less than 4 minutes. Frequency here is 600, frequency here is 200. So starting from more than 4 hours, next is less than 3 hours, then 30 minutes, less than 10 minutes, and less than 4 minutes. Here I like to add up one more condition, which is a differential diagnosis for cluster headache. There is one more condition called hypnic headache, which also has got circadia. Hypnic headache here, the word hypnos means sleep. It happens here in the cluster headache. Usually, the headache is after 1 or 2 hours after the patient goes to bed. And male and female ratio is the same. Hypnic headache is more common in females around the age of 50, and it is common between 1 to 3 a.m. That is almost 3 to 4 hours after sleep. And the headache is bilateral, not unilateral. It's bilateral, not severe like cluster headache. It's a dull headache, and the duration is approximately like cluster headache, say 3 to 4 hours. It responds well to indomethacin. This is a dull type, between 1 and 3 a.m. So in this condition, we need to rule out sleep apnea and nocturnal hypertension. So the 5 different types of headache now I can rush up with other simple type of headache like tension headache, where the patient says he has a feeling of band-like a compressing headache and also pain in the vertex, and definitely there will be a history of stress and strain. On examination, he'll have the ENT examination will be normal. He'll be giving a history of stress and strain, and there will be tenderness in the scalp muscles and the neck muscles also. Imaging is done just to rule out other conditions, and treatment is we'll have to avoid smoking, have a normal sleep, normal proper 6 to 8 hours of sleep, and regular diet, not to skip any diet, well hydration. If medication is to be required, he has to take anti-anxiety medications like Alprax and amitriptyline. Next, we'll go on with behavioral therapy, the last being antidepressants. Next, we'll come to simple ones like primary cough headache. In this cough headache, which is classified as primary and secondary, I am worried only about the secondary one, where the last one which I have listed, brain cancer in the posterior fossa, which will be taken care of by the neurology department. Now, coming to the next variety, which is exertional headache. The patient complains of headache only when he exerts himself too much, especially in a dehydrated state. When he goes to gym, he goes for jogging, and in a dehydrated state, the temperature is very high, conditions like that. So what happens is, during this condition, the scalp muscles go into spasm, and there is vasodilation of the scalp vessels, leading to headache. So we have to advise a self-limiting condition. We have to advise a proper hydration for him along with electrolytes, and he should know the limit of exertion. Suppose if he has noticed that the headache starts by 40 minutes after he starts the exercise, we have to tell him, try to stop within 30 minutes and try to slowly increase. The best medication for that, if suppose we have to add up any medication, indomethacin is best for it. Coming to nummular headache. The word nummula means coin shaped, and this is very rare. It responds very well to gabapentin, and even the medication is not given or prescribed, it goes off, spontaneously goes off its own. Thunderclap headache, where the headache reaches the maximum intensity within a month. The main differential diagnosis for that is subarachnoid hemorrhage. Coming to cervicogenic headache. This is mainly because of the neck strain. If you see the picture here, the first one, which is normal position, second one, if you flex the head by 15 degrees, it is as if you are placing 12 kilos in the neck. 12 kilos equivalent pressure in the neck. 30 degrees, 18 kilos equivalent pressure in the neck. 45 degrees is 23 kilos equivalent pressure in the neck. And last one is 60 degrees, where 27 kilos equivalent pressure in the neck, the commonest being the 45 degree. So what happens here is, because of that, we have neck muscle spasm, and the patient will complain of headache also, mainly occipital headache. Now, we need CT cervical spine and MRI cervical spine. The best thing to do is refer to orthopedician and neurologist. From our side, what we can advise them is exercise and physiotherapy, mild NSAIDs and anticonvulsants if necessary, and about the surgery part will be dealt in detail by the neurologist. There are few exercises to be done. We have to ask the patient, I'll just tell you in very fast, they'll have to ask the patient to turn left and right 10 times, up and down 10 times, and on the right up and down 10 times, left up and down 10 times, and clockwise and anti-clockwise rotation also. The next one, we have to ask the patient to exert pressure against resistance in the front, and same thing behind also on both sides, like how you see in this video. This is one. We have to ask them to do it 10 times. Then from behind, place your hand in the occipital region, ask her to push. So repeat 10 times. Likewise on the sideways. And on the right side 10 times, left side 10 times. Now coming to this exercise, stretch your hand, flex your neck. Count till 10, relax. She has to do that. We can ask them to do warm compression, which has to be placed for a few minutes. This is mainly done by the physiotherapist. We can release the trigger points. So this is the four exercise which will be done by the physiotherapist. This is, we are releasing the trigger points. Then we can do ultrasound, which is done over a period of 5 to 10 minutes. In the session, at least 5-6 sessions is needed. And the last one is TENS therapy, that is transcutaneous electrical nerve stimulation. Here also, we need at least 3 to 5 sessions, so that all the neck muscles and the back muscles, these are relaxed. So chronic headache, the last one, this can be classified as long duration, short duration. Long duration, short duration we have triggered and non-triggered, and long duration we have chronic and tension headache. Short duration triggered we have primary cough headache, the exertional headache, and short duration non-triggered we have cluster headache, paroxysmal headache, SUNA and SUNCT. So that brings us to an end of headache. Thank you so much.